kōrero in this podcast are of a general nature. For specific advice, please talk to your tākuta or tohunga. It's Kōrero Prescriptions. Because kōrero is healing. He rongo a te kōrero. Nau mai hara mai ki tēnei pakihere roki roki. This is Kōrero Prescriptions, the podcast where you take what you will from the kōrero as your prescription, but I must tell you that everything we talk about is quite generalised, so go and seek professional advice for your specific ailments and illnesses. Today, we are going to talk about Mate Huka. No, this is a touchy subject. A lot of our people have Mate Huka. If not, I think it's 1 and 2 stages. And generally in pregnancy too, a lot of Māori women have diabetes in pregnancy. So with us we have a mātanga I te ao hauora, Dr. Leanne Te Karu. Now tell us, what is this thing? What is diabetes?
I guess we kind of broadly call diabetes type 1 or type 2, and they are very different health conditions, so I suppose it's quite helpful to point that out from the start. Type 1 diabetes is when there's no insulin in your tinana at all. There's something called your pancreas that pumps out insulin in response to kai. And in type 1 diabetes, the pancreas has been completely blown out. It's not working anymore. It's an immunity type thing. So those people absolutely need insulin and can't live without it. So a very different approach with type 1 diabetes. Type 2 diabetes is when your pancreas is still pumping out some insulin, but it's not working in the same way, so you're not getting the food absorbed into your body so well, and the sugar sits in your toto. So your sugar levels inside your blood are higher, which is not good. It makes our toto quite syrupy almost, like golden syrup. So it's flowing through your tinana quite thickly, and it's not something that you want for sure.
And then what is gestational diabetes?
We do see, well, in actual fact, I'll come back to the start and say we don't know for sure who has diabetes, both type 1 and type 2 and gestational. So we don't have any real robust data in Aotearoa and in this rohe on it, but we can anecdotally say that we are seeing more gestational diabetes, and often when Pepe's born, you can go on and not have diabetes anymore, but our babies are bigger, born bigger, and are a little bit more likely to get diabetes later on too. So it's the way that we use sugar in our tinana, and I was going to say sequelae, but the consequences of when that sugar is high for a long time and what that can mean and why you would want to have that managed.
What is it about our lifestyle that makes us more conducive to getting te Mate Huka?
And it's no accident, Raiha, that communities that are struggling, you see more fast food outlets, that, the likes of your fizzy drinks are more accessible. Let's go to Tamaki Makaurau, not to, cast aspersions in places, but, your Mangere, your Papakura, South Auckland versus your Remuera or, I don't know, the towns around the basin.
Yeah, there's certainly no KFC in Remuera.
No, exactly. And, so it's that kind of environment that people are exposed to all of the time.
So I know we've talked a bit about genetics in our other podcast. Is there some of that at play here too?
I'm always a little wary about talking about genetics in the diabetes space because I don't know if you remember that terrible time about the warrior gene. Yes, so that some of that was had a platform from the diabetes space, but we know certainly that we weren't exposed to the type of kai, pre-European days. So, all Indigenous populations across the world have the same struggles in managing the things that are put in our kai these days. Fructose is a sugar, anything that ends in O's.
So this is one thing we can talk about as has a correlation with, colonization. But what are we doing to, like, in the health system? I mean, you said there was a gap between diagnosis and then treatment. Are there disparities with the treatment side as well?
Absolutely there is, Raiha. We lobbied so hard to get some medicines here in Aotearoa that have been available in other countries for more than a decade, medicines that show, for the first time ever, that you can stop that increase in mortality with diabetes with these medicines. So they became available in 2021 after so much advocacy and kind of backyard deals and kind of meetings outside of buildings, and then we had to make sure that they would be implemented in a way that was equitable. And what people don't understand about equity is that you have to apply things with unequal to get an equal outcome, so some people might get more to get an equal outcome. In the Pharmac schedule, so the Pharmac are the people who fund the medicines, and we managed to get something in the way that these medicines were prescribed to say that if you were Māori or Pacifica, that you got these medicines without having to jump through all these other hoops. And we've been able to demonstrate that that was a real game changer, that unequal input did lead to an equal outcome. There's technology now, like to manage your sugar levels, you can wear something called a continuous glucose monitor that rather than, really old days, there's some diabetics.
Pricking and...
Yes, pricking.
Yeah.
It used to be a mimi test way back in the day. Oh. There's some diabetics in Tūrangi that will remember those days. And so that's really hard to manage because what you're actually doing is looking at a sugar level that was a few hours ago. It's not the right here and right now. Yeah, so these kind of flash things now you can wear in your arm and they will tell you what your sugar level is all the time. And for people with type 1 diabetes, which we think is about 25% of the total number, is you can get a insulin pump. So an insulin pump that talks to this glucose meter now. So it's almost like you've got your own pancreas. And we're hoping in time that type 2 diabetics will also be able to access the same kind of technology. So
it's about money though, right? That sounds like it's not cheap.
The insulin pump isn't. The glucose monitors are coming down in price all the time. There's also, so there's new pill medicines. There's also, and I think some of the listeners may have heard of the medicines like Ozempic that I understand the Kardashians, who I don't really know about, but I understand they kind of made them a little famous because they were using them as a weight loss medicine. So then they became in short supply throughout the whole world because people, from what I understand, didn't particularly need them.
Right.
Were taking them, and those people that do, and of course don't have the means of paying for them, missed out. So there are these medicines now in Aotearoa that help manage diabetes, but also make you less hungry. I guess you feel more full, so helpful for losing weight as well. Yeah, and also help look after your kidneys. So we're trying to make sure that they are being prescribed in a way that is equitable. So unequally in some people's eyes, but to receive equal outcome. And like I say, the data that we're seeing currently is really, really satisfying.
That's awesome. So there you go, Te whānau. If you don't need it, don't take a Zempic. If you're already skinny, you don't need a Zempic. Save it for the aunties. But this is an interesting kaupapa because a lot more whānau are being prescribed a Zempic, or even, So what has been the impact of that on diabetes?
So they shouldn't have been getting Ozempic for diabetes. They might be getting something called Trulicity, and obviously they all have terrible names. Yeah, I don't know who makes them up, but they're all really hard to say.
Well, if it doesn't have a Z, it's not boujee. So. Right. And then, have you seen whānau reach out to rongoā, and what has been the impact of rongoā on diabetes?
I mentioned a clinic that I run in the Waimarino. What he did was take the people with diabetes together, and ended up that they would make their own rongoā, wairongoa, and kind of get together. And I guess whether it's the combination of the fact that they had this kind of social interaction or going into the ngahere together to make rongoa, and then first thing in the morning having at least 250 mils, sometimes 500 mils of so a couple of cups of the wairako, to drink every morning. We're seeing really great outcomes just from that.
I mean, it's technology and everything has evolved. Has it evolved to a place where we can completely cure people, or just get better outcomes?
A bit of both, probably. So the type 2 is preventable. We can prevent that coming on. Type 1, we don't know how to prevent that, but this whole system of a insulin pump talking to a sensor that's monitoring your sugar levels, and then it releases insulin into your tinana.
That's boujee. That's like R2D2 stuff, eh?
And I'm sure that that's going to be more and more refined.
We have health insurance, but they don't cover these sorts of things. So you still have to have a fair bit of pūtea just to get access to them.
That's so true. Yeah, I think we're also doing a disservice sometimes if we don't ask whānau. Like, some of the medicines are funded if you have type 2 and type 1 type thing. There's some medicines that require different, what we call clinical factors. So this HbA1c thing, you might get it if you reach a certain level. And sorry, where I was going with the metformin thing is that quite often in the past, doctors would get back your HbA1c level and see that it was really high, and they would start you on this metformin medicine. And what we know about metformin is that it really upsets your puku. Terribly so. So people almost can't leave their houses sometimes if they're prescribed a dose that's not correct. You really do have to start low and go really slowly. So again, there's a bit of a perception from our whānau that it's a bad medicine, or, that it's just not worth having, but it can be really helpful, and it can help you to lose a little bit of weight too. Right. So it's usually the starting point. But again, when we look at the data of who gets what medicines according to ethnicity, Māori miss out again. One of my, I have 2 Waitangi tribunal claims, and one is on medicines in totality. The medicines that we need, we don't get, and we get medicines sometimes that we shouldn't be prescribed regularly. Yeah. So it's about getting that balance right.
Yeah. Well, and I guess, having podcasts like this where we are a bit more informed about what's going on, because quite often we don't know how to advocate for ourselves in these spaces. We don't know that, certain things are available. And even in your story, I know doctors say that there's a lot in your story. Knowing what to say in your appointments can open different pathways, yeah?
Oh, absolutely. And it's about having that relationship. And that's the part that I really love in the mahi that I do, and ensuring that people feel like they can pass over all information, and, let's triage through that sort of thing. But, I don't think that our whānau have always, if I'm really honest and think of my own whānau, to have felt the ability that they can share everything. And sometimes I think as clinicians too, we need to be better at recognising it. I think the first time I ever had a person having a full-blown heart attack on me was a Māori man who turned up early for a diabetes appointment, a diabetes check, just a kind of, let's see how your medicine's going. And he was there waiting for me when I got to work, and he was on his own. Māori man on his own and, come for his diabetes check. And so your radar goes up a little bit, and like, what else is going on today? They've got this indigestion, this indigestion pain going on. And so how about we do an ECG? That's when we put some leads on your heart to see how your heart's going. I really think we should do that, Leanne, so he'd already kind of, but if he hadn't, if you're kind of picking up cues on both sides, but absolutely you've got to have that relationship where people feel safe enough to share everything.
Right. Now, we know diabetes doesn't just affect, your limbs and your hands and your eyesight, but if not managed well, then what are the impacts on everything else, like your heart and your kidneys?
In particular, your heart and your kidneys are affected by diabetes outside of the things that you've already mentioned. Kidneys especially so. We know that the most people who have what we call renal failure, so kidneys that have got to the stage where they need help, like dialysis. So that could be dialysis at a centre where you go to have hemodialysis, or some people do dialysis in their own homes, or what we call peritoneal dialysis. That the majority of those people who have end-stage kidney disease have had a pathway of diabetes that's been mismanaged. Also gout, but predominantly diabetes. And we know that it impacts upon your heart with high blood pressure, and sometimes your heart not beating in the same rhythm. So significant impact on the rest of your body.
Particularly in our iwi too, and they're getting younger.
They are getting younger. Māori are 10 years younger at the kind of end stage renal to kidney disease than non-Māori. I think it's a blight that we don't have dialysis services in Taupo or Turangi Rohe, and it's been something that I've been trying to advocate for some time.
And I know a lot of our whānau even have issues with taking those tests. And I mean, you can do a male, in the male test for bowel cancer now. So, I mean, having a mimi test and a blood test at whānau, not to, it's not that invasive, but it could actually prevent a whole lot of misfortune and having to go to Rotorua. I know a lot of our whānau here, and there's even that travel subsidy for healthcare, but it's so hard to get.
Oh my goodness, you have to fill out a master's thesis to get it, to access it, but it's also only a drop. It doesn't cover, your expenses completely. So,
well, you know what? I'm glad we're having this conversation, because even if our whānau out there take a little bit away from the puna of mātauranga you've just like dropped like a mic. I know we'd be better off no reira e mihi ana ki a koe. Do you have any last kōrero, whakahau, any last pieces of advice or wisdom for those suffering from Mate Huka?
I was only going to add in then, Raiha, about the mimi test. You can drop it back. I quite often give people the vial to take away if that's, any kind of raru or anything. Just drop it back into wherever the lab or, to the clinic or whatever, to the marae, and we can, do that part for sure. But don't forget that rongoa approach as well. So,
Absolutely. So don't just give a man a fish. Teach them how to fish. Ana, koira te oranga mō te iwi. E te iwi, tēnā rā koutou I tūhono mai ki ēnei kōrero. I hope you can take a little bit away from this kōrero as a prescription for you. Engari e mihi ana kia koutou ko tūhono mai ki tēnei Pakihere Roki Roki, a Kōrero Prescription. This podcast was sponsored by Raiha Whakapikiora, production Tu Wharetoa Mohi, post-production Raiha Paki, director Tu Poutama Paki, production manager Sierra Tulloch, producer Tu Poutama Paki, presenter, researcher Raiha Paki, executive producer Leanne Puohotaua, reo en tikanga QA Hinana Media, production house Tu Wharetoa On, production assist Raylene Walker.
Kia ora whakapikiora is our opportunity now to put into action the aspirations of our people.
Really important because it's helping us to come together as providers for our whānau. So, not even that whānau, for our whānau. Kaimai.
We're either tū wharetoa by whakapapa or we're tū wharetoa because we live in this lohe. And so when you peel some of those layers back, actually the challenges become opportunities to come together as whanaunga and opportunities to work better together.
So our whakapanui is to support our kaumātua to access services.
I hope to see come out of it is that we actually be real, we be honest, and we look at each other as whānau, not as providers and all the dissections that we have.